BSSH webinar this evening, The Great Debates of Hand Surgery. You know, we're all going through troubled times across the whole world at the moment with this dreadful coronavirus. And it's changing the way we work, changing the way we look at our patients, our friends, but also it's changing the way we can have meetings and the way we can learn and teach. We ought to be having our BSSH scientific meeting this evening. There'll be a banquet with street food. There was going to be dancing of the West End Jersey boys, beer and wine. But you know what? We had to cancel that because of coronavirus, and tonight's debate will be even more fun than what we planned before. Now, believe it or not, there are nearly 600 of you have signed up for this webinar tonight. And it's not just the BSSH. We've got people from Russia, the Middle East, Canada, USA, Cuba, Brazil, Argentina, and even Colombia. In fact, I'm wearing a Colombian Hand Society badge right there. My wonderful colleagues will come to the rescue to try and help out tonight and provide this webinar for you all. Firstly, Emma Brighton from the BSSH has organised the really very complicated PowerPoints and the Zoom video system. And she's ably helped by Max Horitz, who's one of our council members, who's in the background tonight, making sure this all works well. You've just heard from Zaf, who's our BSSH social media guru. And we'll also have Nicola Goldsmith, who's the current president of the International Federation of Societies for Hand Therapy. And Zaf and Nicola will be running each of the debates. We've got faculty from the USA and from Great Britain. And they've all been primed to take a light-hearted, biased, but informed view to try and make the debate work well. And you, the audience, have got the chance to ask questions as well as we go along. So please, all of you, sit back and enjoy the BSSH Great Debates of Hand Surgery.
Thank you, David. So we have what promises to be two fantastic debates on controversial issues. Some housekeeping before we start. The debates will centre on case studies that the experts have provided to us. And you'll have the opportunity to have a look at how they manage their patients. Following this, there will be a vote. You will vote, and you'll have 15 seconds to vote for your preferred expert after each case. You'll also be able to post questions throughout the debate using the question and answer facility. You can see this at the bottom of your screen right now. Please submit your name and where you're from when you submit your question. The event is being broadcast live and also recorded for YouTube, and you should bear this in mind when submitting your questions. Now you can move the images of the speakers around your screen, just in case you need to see the whole of the slide. And also a little reminder, at 8 o'clock, we will be pausing for a few seconds to clap for our carers. Thank you, Emma. So, I'm personally very excited to host this first debate on phalangeal fractures. We're talking about the tiniest of breaks in the tiniest of bones, but we all know just how much pain and misery these bones can cause, and these injuries can cause, not only to the patients, but also to ourselves as their clinicians. Just look at these quotes from the pioneers and experts in their fields. John Charnley has said, quite rightly, that the reputation of a surgeon will stand in as much jeopardy from this injury as from any fracture of the femur. And Al Swanson, very, very excellent quote here. A hand fracture can be complicated by deformity due to no treatment, stiffness from overtreatment, and both stiffness and deformity from poor treatment. So the stakes could not be higher. We've got two surgeons who are putting their reputations on the line to go head to head against each other. This is like Madison Square Gardens, a transatlantic tussle. And it's my pleasure to welcome Giddins, orthopedic hand surgeon from the University of, he's a visiting professor from the University of Bath, whose research includes tendon pathology, the mechanics of falls and joint replacement and instability. Gray was editor-in-chief for the Journal of Hand Surgery, European, 2012 to 2016, and more recently our president of this great society in 2017. Gray, could you give us your opening statement, please?
Oh, thank you. Thanks for bigging me up. It'll only go downhill from here, but yes, I really want to emphasize that, as we know, most hand fractures can be treated non-operatively, and it does get more difficult with the phalangeal ones. But when I'm talking about these fractures here, I'm considering the average patient treated by the average surgeon, not an Olympic athlete treated by the world's best hand surgeon, who isn't me. And we should not operate under certain circumstances, and quite a lot of these apply. When non-operative treatment is so good, it'd be hard to improve on it. And when research shows that operative treatment is no better than non-operative treatment. And we should always bear those in mind and keep up to date with the knowledge. But one question I really want you to hold in the back of your mind in all of these debates is, how many patients need to be a little bit better with surgery for the one who is so much worse? And if you haven't yet come across them in your practice, you will.
Thank you, Gray. Now, challenging Gray, it's my pleasure to introduce Glenn Gaston. Glenn, from across the pond, is Chief of the Hand Service at the Carolinas Medical Center. He's been Chief there for 12 years. Glenn is also heavily involved in research, receiving numerous honors and awards from both the American Academy of Orthopedic Surgeons, but also the American Society for Surgery of the Hand. Now, Glenn is currently writing the chapter on phalangeal fractures for the prestigious textbook, Green's Hand Surgery. It remains to be seen if tonight's proceedings have any impact on that. Glenn.
Thanks, Zaf. I wanted to start by cautioning the audience not to fall victim to the well-accepted dialectual bias that exists in this debate. It is no secret that the British accent has long been emblematic of superior intelligence, while my southern U.S. redneck tongue has been more affiliated with ineptitude and illiteracy. So I don't want people to forget when they're voting, we're voting on intellect, not dialect. But in terms of my overall management of phalangeal fractures, I'm going to speak to you about the operative management. And of course, I still treat the majority of phalangeal fractures non-operatively in my practice. But tonight, hopefully, we'll focus on a few controversial cases in which you could kind of go either way. And I'll make the case for when I think surgery is perhaps the more prudent approach to these injuries. We'll talk about whether to pin them, screws, or ORIF. And I think it's also important to remember, attached to these fingers are unique patients with unique needs. So we need to consider the individual as a whole when approaching the fractures, as oftentimes doing surgery will let people get back to their life, their sport, or their work sooner than if we strap down their hands and prohibit their use.
Thank you, Glenn. So let's go to the first case then. So this is Miriam. Miriam's 40 years old. She's right-handed and she's a dentist. Miriam fell whilst jogging. She's injured her right little finger, as you can see from the x-rays. She was seen in an urgent care setting and splintered without any reduction. She presents to our surgeons after 9 days. I'm going to ask Gray, what do you think about this? Gray, what would you do here?
Well, I think this is always a bad injury. These, in my experience, can easily go wrong on you. It looks pretty innocuous, but patients can get a lot of pain, and I'm wary with this. But recently, I've tended to treat these with strapping, assuming I can get an adequate reduction. I'm not going to get a perfect reduction, but as long as there's dorsal angulation of no more than perhaps 10 or 15 degrees, I strap them down. I show the patients how to change the strapping. I get them to mobilize, release the strapping at least once a day, get their hand in warm water, ease it up. And I found that they mobilize quickly. It's not too limiting. I think they can get back to function pretty quickly. It does depend on a cooperative patient, and we need to keep an eye on them for the first few weeks. But I've been very pleased and found that I've had few complications and not so much of that PIP joint stiffness and pain you can get.
So Gray, would you classify this as a stable or unstable fracture?
Well, I think you can't really see that until you've attempted to reduce it. Sometimes you can be surprised, but I would expect this to, if I tried to reduce it, would want to tip back into extension.
And just because I'm picking you up there, you said that on a daily basis you get them to take their strapping off and mobilize their fingers. So we'll hold that thought and we'll come back to you. I'm going to ask Glenn to give us his preferred management.
Yeah, for me, we've got a young patient that's a dentist. We've got the classic apex volar angulation to the fracture. The small finger in particular seems to be one that's even more prone to the pseudo clawing as opposed to the more radial digits. So for me, with someone that's going to need to get back at work, they're not going to tolerate immobilization very well. This to me is a case that would be much better served in my hands with operative treatment.
Okay, and so which type of operative treatment are you advocating?
Yeah, for me, phalangeal fractures, virtually all phalangeal fractures, I've moved towards a wall-aunt approach. So I would have the patient wide awake, would numb the digit. And my plan for this, because it's a very proximal fracture, I think would be hard to capture with plates and screws. For me, this would be one that I would try to pin. My primary goal would be to pin it starting on the radial and lateral edges of the proximal phalanx. And if I wasn't able to get it pinned in that manner, I would consider an Eaton-Belsky pinning going through the metacarpal head and across the MP joint while that's placed in flexion, leaving the IP joints free.
Okay, thank you, Glenn. So I'm going to ask the audience now, if you could vote now. You've got 15 seconds as to which of the expert has convinced you is how you're going to manage this fracture. Okay, so let's see. So it's pretty close actually, but Glenn, you've won over there. So let's have a look at
a comprehensive win for America, I have to say, sadly.
So let's have a look at what actually happened here with the next slide. And Emma, yeah. So actually, this is what happened. Glenn, this was your patient. So just talk us through this if you can briefly.
This is a case of mine, as you can see. I was able to get it pinned working around the metacarpal head, trying to stay straddling the extensor tendon so as not to impale them. I think one nice thing about doing these under Wallon is you can watch the patient move it right away. And while typically I leave my pins outside the skin if I'm going to have them in for only 3 to 4 weeks, in a dentist, this would be one I would cut the pins beneath the skin so that they could wash their hands, which they need to do frequently throughout the day, and have them hopefully back at work within a few days with the pins beneath the skin.
When are you taking these pins out, Glenn?
Typically between 3.5 and 4 weeks.
Okay. And you don't have any worries about what you're doing to the soft tissues by sticking these pins in?
I always have worries. I think there's Tom Fisher told me that K-wires, first they penetrate, then incinerate, then suppurate. And so I do have concerns every time, but I think for this patient, those concerns are outweighed by the benefits of having fixation and letting them get back to work and mobilize early.
Okay, so thanks for that. I've got 2 questions here. Will Mason from the UK and also Aristo from London, Aristo Basso. They're talking about conservative management. So I'm going to actually go to the next slide. Emma, if we could go to the next slide. And I want Gray to try and explain his methods of splintage here, please, Gray, very briefly.
Yeah, so I've used lots of treatments, plasters, splints, all the stuff, but I find this the best. I just strap them down, not beyond 90. I try to go at about 80 degrees. You can check on the X-ray. The patient can move within this. There's quite a bit of elasticity at the MP joint as well. They take that off every day to just gently stretch out and then strap down and wear it overnight. And I find over the course of about 3 weeks, they do very nicely in this, and then you can increasingly mobilize. I think as you can see, most of the hand is free to be used day to day. And I've been very pleased with this as an approach.
I guess you rely on your patient, don't you, quite a bit here for compliance?
Yeah, absolutely. I think if you haven't got compliant patients, then you would be worried. And as I say, we're talking about the average patient. Fortunately, in Bath, the average is quite high. So we've got nice cooperative patients who come back.
Okay, thank you. Let's move on to the next case. Oh, we have here some images of Glenn pinning. And Glenn, just explain here, you're going through the metacarpal head here?
Yeah, this is a different case. It was just to illustrate that if you're unable to capture the proximal edges of the proximal phalanx with the that approach, another option is this Eaton-Belsky pinning, where you simply go through the metacarpal head across the MP joint while it's held in about 70 degrees of flexion and down the canal of the proximal phalanx for fixation, as you see here.
Yeah, I mean, this to me looks pretty brutal on the articular surfaces, and also I'd worry about where do you cut the wires? Could you address those issues?
Yeah, so I agree. This is not my preferred technique, but if you can't get it fixed the other way, this is to me the second best option that you have. This would be a real treat, not this particular one. The case we showed earlier would be a really hard one to fix with a plate and screws. I tend to across the board leave pins outside the skin if I'm going to pull them in less than a month, and I tend to bury them if I'm going to have them in longer than that.
So to be clear here, we've got wires which are out of the hand, but they are transarticular wires, and you're
Correct.
okay with that. You're okay with that.
For a brief period of time, I am.
Thank you. Okay, let's go to the next case. So this is Max. Max is 21 years old. He's a professional footballer. He obviously therefore presents immediately in your office. He's been stamped on. He's probably stamping on you right now, and it's mid-season. So, Gray, what do you think about this?
Yeah, I guess, are we talking proper football or this American stuff?
Well, this is proper football.
Yeah, I mean, as I've said, I've talked about the average player, and I think for a professional sportsman, you may be thinking of something else. But my concern here, this will be a spiral fracture, and I think these are much better treated with strapping. I've increasingly done strapping for these, and the principle really for my work is that I think you can't overcorrect them. Now, of course, if you try too hard, you can, but with judicious strapping, I find you don't. Again, I get them mobilizing early, taking the strapping off regularly, and within 3.5 weeks, they can largely be out of the strapping and get going, and they're not too stiff. So that's what I'd advocate. I think the alternative is the triple operation. Put the plate on and screws, take the plate off and screws, and then do the tenolysis, and then apologize they've got a bad result.
That's a below the belt punch there, Gray. I'm going to stop you there as the referee. I'm going to hand over to Glenn. Glenn, what are you going to do here?
I can take that. So in an American football player, like a real sport, I would probably manage this operatively for the simple fact that these people need to get back and they want to return to sport. If you strap their finger down for 3.5 weeks, then you're going to return them to a professional sport where they're receiving contact and they're still going to refracture it. And then you're going to be on to your next operation of fixing it and then start his cycle of surgery. So for me, athletes need to be fixed rigidly. They need to fix so that they can return to play. I actually like a lateral approach typically, and I'll excise that particular lateral band and put the plate directly lateral most often in these so that I don't get the extensor tendon adhesions that I get with a dorsal approach or an extensor splitting approach for them. And typically for them, for me, I'm getting my athletes back to sport usually in about 2 to 3 weeks. And the period I worry the most about in athletes is if you plate them, you're good to go. If you pin them, or if you non-operatively treat them, it's really weeks 3 through 7 that you really worry about them refracturing, a concern I wouldn't have.
Okay, so Glenn, I picked up there. So you're going to plate this and you're going to basically let them go straight back to sport. That's what you're saying.
Once their sutures are out.
Fantastic. Okay. All right. Okay. So, I mean, do you not think that this is a relatively undisplaced injury right now based on these x-rays?
Yes, if this was not an athlete, this would be a fracture that I would manage closed. But I think, like I mentioned in the very beginning, you got to factor in the whole patient. Although I would say if this was my individual finger, I wonder how many hand surgeons on this call would want their finger treated in a cast for 4 weeks or in strapping and being out of work for that period of time versus getting fixed back to work.
Or indeed operated on, Glenn. Or indeed operated on. Okay, let's go to the vote then. You've got 15 seconds, guys. Please decide which is the preferred treatment. Who's convinced you? And then we've got the vote. Are we having technical issues or?
Did the vote now button get pushed?
Ah, here we are. Whose approach do you agree with, Glenn or Gray? 15 seconds from now. Gray, there's a bit of a comeback here. All right, so Glenn, there you go. Let's have a look at what happens with this case. If we move on to the next slide. So this is a patient that obviously has been under the care of Glenn. And my first comment is, Glenn, do you get paid for every screw you put in over there in America?
One code, Greg. One code, unfortunately. But yeah, he got a lag screw followed with a neutralization plate to back that up with. For me, it helps me be much more confident returning these athletes to sport when they're fixed. Again, I think he would have missed a lot of play time, which would have resulted in not only a lack of income, but a lack of work for this guy. So.
Okay, so Roger Helm here says a rugby player wouldn't even present to a doctor. This is obviously an American phenomenon. There you go.
Very fair. I feel like I need to go back to Ricky Bobby and not Tiger King now.
Okay, let's move on to the next case. Oh, there you go, Gray. Do you want to say you've won this one, but you might as well very briefly explain.
Yeah, the strapping here is a bit more complicated, but this is one who's had a simulated spiral fracture into pronation, so the ring finger crossing over the little, and I'm strapping it back across the other side. Not too harshly, so that you can still get some bend up and down of the finger. They take it off daily, and again, I found this very good. I mean, if this were mine, I wouldn't do anything for the first 10 days, but I'd just get it going, and then I'd strap it at about that point, because I think it's still sticky, and you only need a brief period to hold it over. But with the patients, I tend to strap them earlier to get them used to it.
Okay, thank you. Okay, let's move on. Damien. Now, Damien's 26 years old. He's right-handed. He hasn't got a job just yet. You can see from the x-rays there's been previous injuries, previous fractures. He presents to you at 4 days, not in the private sector. He's not sure how this happened. Great. Well, let's go to Glenn. Glenn, what are you going to do here?
Damien also appears to be a chronic trauma patient with the old mouth that he's got above it. I don't generally favor operative treatment, but I would say that he's got a metacarpal fracture and a phalangeal fracture. I think it's going to be a little hard to hold all of that non-operatively. This to me would be a great indication to do an extensor splint and put a screw down, an intramedullary screw in both of those fractures through one approach, and handle both fractures with intramedullary fixation. Soft dressing, they'd be moving it the next day.
Thank you, Glenn. So, Gray.
Yeah, I mean, I think Glenn's right. I think we're moving on. I think if we were going to fix this, I think intramedullary screws are good, because I think these take a long time to heal. But this was an unreliable lad, and I felt that he'd do better just be treating this non-operatively, waiting a while, letting it settle, and I reckoned he'd probably get going pretty quickly once we released him. So this is the sort of injury I'd just immobilize in an ulnar gutter type plaster for a few weeks. And again, the principle here is that I don't think a few millimeters of shortening makes any functional difference, and we avoid all the risks of surgery in an unreliable patient.
Okay, thank you. So I'm going to put it to the vote. While you're voting, it's just to say we are getting quite a few questions coming through, so I do apologize if we don't get to ask all of them, but I'm trying my best. Glenn, you've got this one there. People feel clearly the sensible thing to do with a displaced fracture, Gray, is to reduce it and fix it. But let's have a look at what happened here with this case. So in fact, this patient had the privilege of being treated by Professor Gray Giddins. Gray, talk us through how you held your nerve with this one, really.
Well, you know, he had a bit of shortening in the ring finger, in the little finger, both the metacarpal and the proximal phalanx. But as you see, he heals in a nice position. He's got good extension. Unfortunately, I don't have the flexion pictures, but I can assure you he bent down well. It's safe. I think the key is this is safe, you know, and I think you want to particularly worry about the middle of the proximal phalanx. That can take quite a long time to heal, particularly if you put wires in. So I would support Glenn. If I was going to fix it, I'd probably put a screw in these days. The wire you can have to leave for a long time.
Would you not plate this under any circumstances?
I'd never plate it.
Okay. Okay.
Yeah, I've moved way away from plates as well, especially metacarpals. The limited dissection of an IM screw you're talking about for an isolated metacarpal shaft, you're talking about a single stitch or a 2-stitch surgery with no soft tissue disruption around it, and they can rehab on a much faster basis. And
Okay.
that's been my approach.
Question to both of you from Alex Nichols. In regular punctures, is anyone worried about a periprosthetic fracture with an IM screw? Well, I guess Glenn, you
No, I'm really not. IM screws, so first of all, when I put them in, I'm usually putting them in the entire length of the metacarpal. So I'm trying to basically span it like you would a femoral nail when I'm putting those in. I have not had a periprosthetic fracture yet in treating a lot of athletes with intramedullary screws. So I really don't worry about that any more than I would worry about them fracturing an adjacent digit.
Okay. Thank you both. So let's move on to the next case. So this is Jason. He's 45 years old. He's right-handed. He's a mechanic. He's out walking the dog. And you can see he's had a twisting injury. They've attempted to do something with this in the emergency department. And he comes to us at 2 weeks. Gray, you can see a mal-rotated finger here. Gray, what are you going to do with this?
Well, I think the key is your margins are small. You can take a bit of angular deformity, 5 or 10 degrees, but if you get malrotation of more than about 5 degrees in one of the central 2 digits, so the middle or ring fingers, you're going to be in trouble. So you've got to explain that to the patient, and you've got to be able to correct it. So I would again correct it with the strapping that I showed. And of course, with all of this, if the patient really isn't up to it, they can't cope with it, they can't understand it, then I'm going to have to think of something different, and I'd probably wire it. But my experience is I've been very pleased with this strapping. Patients can mobilize their fingers. You're not immobilizing them at any point. You're just limiting them as long as you're correcting the alignment. So I've been very pleased with that.
Okay, I'm going to stop you there because it's coming up to 8 o'clock, and we are going to acknowledge the work of the NHS for 30 seconds with the Thursday evening clap. So please join us in clapping for the NHS. Thank you, everybody. So I did interrupt there. Glenn, I was going to move on to you in terms of Damien. Oh, no, this is Damien. Let's move back. If we move forward, shall we? To, yeah, here we go. So, Glenn.
Yeah, this is a case for me. I agree with Gray. You can certainly tolerate supination of the index finger or pronation of the small finger better than you can central malrotation. But even with this degree, you can see the coronal plane malalignment coupled with it. To me, this is a straightforward fracture, and it's a long oblique fracture pattern. It's a very good indication for percutaneous lag screws that make a very small approach on the ulnar side of the digit, reduce this anatomically with a point of reduction forceps, and do 3 screws across that. And I would have them in a soft dressing and working on motion immediately. Again, if the lateral band was directly in contact with one of the screws, I would just excise that little portion of the ulnar lateral band so that I wasn't going to have to worry about my extinction mechanism being stuck down to it.
Okay, thank you. So let's put this to the vote. Do we go with Glenn, who wants to do lag screws, or Gray, who has no access to theatres in Bath? Wow. What do you think about that, Gray?
I've been thrashed. I'm going to walk off now. I can't take it anymore. I'm off.
Okay. All right. Let's have a look at what happens with this case. So this is Jason. This is Glenn's patient. So Glenn?
Yeah, exactly as I discussed. This is exactly what I would do. I added one more screw just for you, Zaf, because you wanted me to add more screws to each one of mine. So
Well, we need to look
internal
after the family,
fixation.
man. We need to look after the family.
That's right.
Yeah.
And my reps, of course. So, but limited internal fixation, you can see this is just at 6 weeks. So you can get these patients moving extremely quickly with a limited approach, not disrupt the soft tissues, and then get an anatomic reduction and allow them early mobility.
So just for the people, because obviously everyone's supported your approach here, there's a lot of trainees on listening tonight. The technical aspects of doing lag screws, which are tiny, these tiny, tiny screws, and the drilling, do you over drill and under drill like the classical lag as described in the textbooks, or how do you do this, and how do you maintain reduction while you're doing your lag screws? Just for the members of the audience here.
Sure, I do. I over drill the near cortex, and so that it's sort of the classic AO principles, and then the far cortex, it just gets the standard core diameter drill associated with it. Typically, I use a pointed reduction forceps. One of the small pointed reduction forceps from the set tends to work quite well for holding the reduction. And you're right, you really have to have a good 3D picture of the fracture in your mind so that you're not drilling bicortically into a single fragment, but rather capturing both fragments when you're lagging these.
Okay, thank you. I am going to move on to the next case, which is Margo. Now, Margo's 35 years old. She's right-handed. She's a pianist. She slipped on the ice and fell. Closed injury. Significant swelling after 7 days. Gray.
Well, you'll be surprised to hear what I'm going to say.
Have we managed to convince you to consider a career in surgery, Gray?
No. I was always told I wasn't skilled enough, so I've had to give that up. I mean, I would point out also that the screws that Glenn's putting in very skillfully, these are probably sort of, I don't know, 1.2 millimeter diameter, a core diameter of 1 millimeter. So your margin for error on each side when you're drilling is about 0.1 of a millimeter. And my hospital, we don't have drills that are sharp enough and run straight enough to reliably do that. So I would caution people that your margins are small. But here, a little bit of shortening like this won't be a problem. There's not much angulation, slight shift off. Provided it unites in this position, this patient should do very well. They don't need to be interfered with. So I would probably immobilize them for 2 to 3 weeks in an ulnar gutter. But with some patients, if I thought they were very reliable, I might just gently get them going, keep an eye. And mostly these don't move very much from this position, and I'd expect a very nice result.
Okay, Glenn, I imagine, I think I know what you're going to advocate here. What do you think? What do you think?
Yeah, certainly, especially when you gave us a pianist. A pianist, of all the people in the world, they're going to tolerate small amounts of malalignment. It's going to be a pianist. A slight malrotation in this patient, they're going to hit the keys differently than they're used to doing. I would get this reduced anatomically. I would do lag screws exactly like the case before and get them moving immediately. I do agree the real estate's small, but then again, for all the trainees on the call, that's why you're going into hand surgery, and that's why you chose it, because you're the best at learning how to do that, and that's what we're in training for. So that's part of hand surgery.
Bit of a below the belt punch on Gray, that one, I think. Okay, so let's just crack on with the vote here, because it's a similar kind of injury.
Now let's hope some people will see the light.
I think maybe some people need to give Gray a bit of support here. Let's see what happens. Now there are some questions. Can I say to Gray and to Glenn, there are some questions coming through from previous cases. You may want to have a look while we wait. So Glenn, you've got this, but let's actually see what happens to this patient. So there we go. So Gray, talk us through what you did with Margo.
Well, I did, as I said, I treated her non-operatively, and I doubt you can get a better result surgically. So she didn't run the risks of operations. We didn't run the risks and the costs of it, and she's done very nicely. And I think this is the point. Though, you know, if you get a really excellent fixation and you go a really cooperative patient, yeah, you probably do slightly better than a slight malalignment with non-operative treatment, but this is a lot safer, and the vast majority of your patients will be happy.
Okay, so there are a couple of questions from, we've got a few minutes because we've done quite well I want to address them. So there's a question here from David Bell. He says, lateral plates have a very poor biomechanical advantage. So this is to address to Glenn. Glenn, what do you think about lateral plates?
Yeah, so actually, so the strongest bone in the proximal phalanx is where the insertion of the, on the lateral aspect of it. So it's the far lateral cortex that actually does have the strongest bone. I agree with that if you're talking about bending forces in the flexion extension plane with just a straight plate with individual screws. But now that we have these 3D plates that are locking plates as well, and you can really add screws at different angles, that's not so much a problem. And the mechanical failure is quite uncommon after ORIF versus extensor tendon adhesions being very common. So for me, the benefits outweigh it, and I've gone to lateral plating, particularly with the newer plates that are out. Great question.
Okay, hopefully that's satisfied Dave.
Can I just interject?
Right.
So you're telling me you're giving up a lot of the dorsal plates because they give so many problems?
Yes.
Thank you.
we're not in court, Gray, but well stated. This is a debate. We're not in the courthouse. Okay, so another question is from Sanjay Miranda. He wants to know about anyone's experience with micro Hoffman X-fix. Do either of you ever use an X-fix in the phalangeal injury?
I would only use it if there's really extensive soft tissue damage and I just really wanted to rest it. I mean, what I quite like to do sometimes is to let these rest, maintain length, let the soft tissue settle, and then I might go and do internal fixation as a delayed procedure. That's the only time I'd use it.
Completely agree. Gunshot wounds, probably the most common indication for me to use an external fixator, or if I'm doing a two-stage approach with a masculate and I don't have room for internal fixation around it, are the two most common indications for me.
Not a lot of gunshot wounds down in Bath, Glenn, just so you know.
That's right. Lots where we are.
Okay. So, Gray, there's a question from Sarah Mee. Would you consider a thermoplastic splint as a fracture base with active range of motion rather than taping in flexion? She feels this speeds up healing, keeps the tendons and extensor mechanism moving immediately, reduces the fixed flexion deformity, and allows function with that finger early on. So, are you gonna take on the therapist, Gray?
Oh, I wouldn't dare do that. But no, I mean, I must say I've tried using thermoplastic splints, and I'm lucky to have some really good therapists. But under my practice, I can't get it to work reliably. I think it's very difficult to get. I think you can't control rotation well with them. And I've largely gone away from them, but I know there are many very good surgeons and therapists who advocate them. So I do think there's an element of horses for courses, and if it works for you, go for it. But I've been really pleased with the simplicity of strapping in cooperative patients.
Okay. Ashwin asks both of you, what is your approach for a pilon type fracture?
Great question. So peel-on fractures of the PIP joint is one time where I like a dynamic X-fix. I like a single wire through the head of the center of rotation of the proximal phalanx and one through the middle phalanx and connected along the sides. That is my preferred technique for the majority of peel-on fractures. There are occasional peel-on fractures with large fragments that are amenable to ORIF, in which case I will do that.
Okay. We tried to avoid ligament and joint injuries in this particular debate. And that reminds me that we will be taking feedback from you all, if you would be kind enough to give us feedback so we can look at further future debates if viable. Anne Alexander asks, would anyone consider using the pool traction splint for a P1 fracture? Utilizes a ligamento-taxa technique and allows for active range of motion and safe alignment. It can control rotation as well. Does anyone have any experience of that? Gray, Glenn, we're being educated here now. Okay.
No, are we talking like the old school banjo traction right now?
Nicola's shaking her head. I mean, I don't know if Nicola wants to. She's if I allow Nicola to intervene in our particular debate. But Nicola, do you have anything to say? No, are you keeping quiet? Okay.
No, if you're happy for me to join in, I've made the pool splint.
5 seconds, Nicola.
I've made the pool splint and I've used it many times from lovely Sarah Bradley and her team down in Poole. It is absolutely superb. Anne is completely right. It allows the ligamento-taxis. It can control rotation. The patients move really well. They can manage their ADLs with it on. and they get superb results.
Okay, you can be muted now, Nicola.
Thank you. Thanks, Zaf.
So another question for Gray from Okzika. So apologies if I've said that wrong. But Gray, the question is, how often do patients come out of the splint to mobilize your digits, the digit? Do you notice any loss of reduction due to this?
Well, because the strapping is elastic, I'm expecting them to mobilize within it. So there's a little bit of mobility. They can be bending the fingers up and down a little bit every day. They can be massaging the tip. They've got lots of access. And then I expect them to come out at least once a day. I typically get them out in the evenings, get them in warm water, gently mobilize it for a while. And I'm accepting we're never going to get a perfect reduction, but then you never get an anatomical reduction anyway because of the plastic deformation of fracture. So as long as there's going to maintain a reasonable reduction, I think they'll do fine. And what we want in the hand is mobility and reasonable alignment, not perfect alignment.
Okay. Question for Glenn from Shanshan Jing. Shanshan says, have you ever experienced intramedullary nail being too short to hold some metacarpal fractures?
Depending on the system you use, it can be a problem because some systems that are out there, the screws only come in certain lengths and certain diameters. So you can usually figure that out really quickly, just knowing what set you're using. So for instance, some people use AccuTrack screws or different, it doesn't really matter which particular screw it is, and they come in set lengths that may not be adequate length for a metacarpal, but there are existing IM screws on the market that have adequate length to cover all metacarpal fractures.
Okay. Couple of questions to you, Gray. One from my friend down in Cornwall. Anmar Al-Shawi asks, any skin problems from using sticky strapping, such as blistering and maceration? And another question from Andrew Clark. Gray, what do you do for your patients who are allergic to tape?
Well, I think it's very good. I've not yet had problems with the tape. I guess, you know, obviously they're allergic to it. That's a contraindication. There's usually some other tapes. But again, like all of this, you know, I'm not rigidly sticking to just one technique. And if that wasn't working for them or they couldn't tolerate it, then I might have to change. And there will be times that I will operate on these patients. But, you know, in the main, I'm expecting to treat these fractures predominantly non-operatively.
Sorry, Gray, did you say you would operate on these patients?
Yeah, I mean, you know, if I can't maintain, as I said at the beginning, we've got to get an adequate reduction. I want my patients to do really well for their sake, not mine. And if the technique I'm using is not working, it's not, they can't tolerate it or whatever, then yeah, if I have to change, I'll change.
Fantastic. It was just nice to hear you talk about operating there, Gray. That's good. Good. Okay, I'm just having a look now before we hand over to FDP. I can't see any other questions really. I have one question here from Christina Lipide. Again to you, Gray, really. When the patient takes a dressing off daily from warm water and mobilizing, are you losing reduction? And you've kind of covered it, but it's just to emphasize the point, because this, what you're advocating, seems to be quite opposite of what we're taught really when we're right at the start of our careers in terms of stability and maintaining a reduction. So just, do you want to address that again? You've got...
Yeah, I think that's right. But that's why if it were my hand, I wouldn't strap it for the first 10 days. I just want it to get going, get the swelling down, accept the malalignment, and then reckon that about 10 days I could still correct it. And as long as I got reasonable correction, which I could do, I'd strap it probably for about 10 days. I think it'd be pretty sticky by then. And then I'd reduce strapping, except probably at night. So we know the fracture's going to heal. We just need to nudge it at that right point. And actually, I think trying to over-reduce it early when they're very mobile is probably not very valuable.
So great question from Saudi Arabia, from Abdullah Khatan. He's asking, when you're talking about the position post-reduction and post-strapping, are you just doing this by eyeballing the fingers, or are you x-raying every week?
Both. I'm looking at them carefully, and particularly for rotation, which I think is a clinical assessment, but I'm also taking x-rays. And I mean, if they were badly aligned, you know, really out, then that would obviously change my approach, or I'd restrap it or something. So yeah, it's quite labor intensive in clinic.
Okay, and the final question to Glenn. Some metacarpal IM screws are variable pitch, such as the AccuTrack, but others are fixed pitch. Do you alter your choice depending on the fracture configuration or the degree of comminution? So just talk us through that, please.
Yeah, so I do actually. So if it's a comminuted fracture or a fracture that's going to be less length stable, then I'm more likely to use one that has a fixed pitch or very little pitch variation within it. If you've got a more transverse fracture, then the variable pitch screws can compress a little bit better across that. So I do use that in my decision making. But to be honest with you, the number one thing you have to do is template the screw over the metacarpal at the time of surgery. So lay the screw on top of the metacarpal and take a fluoro x-ray shot and make sure it's going to fit within the canal. Because a much bigger problem than pitch tends to be trying to wedge a screw in that's too big or putting a screw that's too narrow down a wider metacarpal. Bear in mind the ring's got the smallest metacarpal diameter, inner diameter, so you're going to have very much smaller screws for the ring metacarpal fixations.
Okay, that question was from Giles Becker. Thank you for the answer. There are other questions coming in, but I think we will now make way for FDP. I think from my assessment, it looks like it was America first there, Glenn, in terms of the debate. Absolutely in line with the times right now, America first. So congratulations to Glenn, and we hope you guys are all safe over there in the US. Thank you to everybody on my panel. And I'm going to hand over now to Nicola, who's going to take us into the second half on FDP injuries. Nicola.
Thank you very much, Zaf. Actually, I'm just going to invite David, who is going to do us a little midway. I don't know, David, if you want to unmute yourself. You were planning a few words.
Go. Well, I hope you're enjoying this as much as I am so far, everybody. It's been fantastic. I've learned lots and lots and lots. And I think the way the questions work are also very helpful. So please ask the questions as you go along. Just to remind you all, you've seen we've got 2 meetings coming up you might be interested in. There's the meeting in Winchester in the autumn, BSSH meeting. And of course, there's 2022, which will be the BSSH's chance to act on behalf of IFSSH and have the big international meeting. That'll be at the Excel Centre in 2 years' time. So anyone that's listening in is more than welcome to come to either of those meetings. So please do that. I think now we might be ready to get back onto you, Nicola.
Thank you very much, David. Thank you. So it's a complete honour to have been asked to chair the second debate this evening. So thank you very much, BSSH faculty, for inviting me. Flexor tendon management is, as Jinbo Tang said, a challenge and a frustration. So the decision whether to operate or not, post-operative care, achieving a satisfactory outcome remain topics of debate and challenge for hand surgeons and hand therapists alike. So the cases we're going to look at will highlight some of the decision making and explore how we best ensure a good outcome and avoid the known complications for our patients by making the correct initial decision to operate or not to operate. So I'm delighted to introduce to you the 2 surgeons this evening who are going to be making the case for either side of the argument. So first of all, we have Richard Baker, who's been a consultant at Wexham Park in Berkshire for 4 years, specialising in wrist and hand surgery. He trained in plastic surgery on the London rotation and undertook his hand fellowship in Nottingham. He'll be advocating the non-operative route. And Drew Fleming is going to be advocating the surgical route. He's originally from Zimbabwe, as you'll hear from the lovely accent, and trained both undergraduate and postgraduate in plastics in Cape Town, South Africa. Then Drew did his fellowship in Cape Town before coming to the UK, where he took another couple of fellowships at Great Ormond Street and then the Windsor, St Thomas's and Stanmore rotation. He's now been consultant at St George's London for 20 years and has a special interest in children's and adults hand surgery. So I'd like to now pass to Richard if we can have the next slide, Emma. Thank you. So Richard, would you like to talk people through your case against repairing FDP injuries?
Yeah, thank you, Nicola. I am talking about single digits in which the FDS is intact We know from our treatment of Dupuytren's that immobility of the PIPJ is disabling. Conversely, when we fuse the DIPJ, usually an extension that is well tolerated, and that's because the functional range of motion in the PIP is broad and mainly in flexion, and in the DIPJ is narrow and mainly in extension. In fact, the DIPJ is only responsible for 5% of the overall flexion arc of the finger. If you don't repair your FDP, you get a total active motion of 73%, which is good. You get a Strickland score of 59%, which is fair. You get a Buck-Gromko score of 13, which is good, borderline very good. You only get a 4% level of impairment of the hand. We know that there are a myriad of complications associated with FDP repair, and we know that it delays return to normal life by at least 2 months. We also know that there are several factors that predict a poor outcome, such as mechanism of injury, non-compliance, comorbidities of the little finger. So I put it to you that the PIPJ has a much greater functional significance than the DIPJ, and that risking PIPJ motion for DIPJ motion is a poor trade-off. FDP repair may give a worse outcome than no repair, and therefore I think we should give patients the option of no repair much more often than we actually do. Thank you.
Thank you very much, Richard. So Drew, would you like to make your case for repair?
Thank you very much, Nicola and Zaf and Max, for your very kind invitation. I'm acutely aware that you seem to have chosen 2 rather bald plastic surgeons for the honor of talking to our many attendees tonight. And I'm also very aware, looking at my visage in the screen here, that there's a very shiny bit off the top of my head. I do have a little beanie here, which will probably irritate a lot of my English co-surgeons and trainees. It's a Springbok beanie, and Glenn, you might like to find out about this later on. I'm happy to take that off if you'd prefer to see more of me, but I'll certainly use it for my opening statement. So I think in terms of the FDP, we've come, and flex tendons in general, we've come so far from the preclinate areas, preclinate area where all flexor tendons were simply treated by suturing the skin and coming back at a later stage to consider a reconstruction. I'm a personal advocate of fixing the FDP. I like to try and restore normal anatomy. And I also am a personal advocate of flexor tendon reconstruction. Both of these operations, I think, are good in a carefully selected patient, especially the tendon reconstruction. But generally, I will go for FDP repair in the acute situation in all circumstances, unless there's a real strong indication not to. Obviously, factors such as age, the mechanism of injury, occupation, hobbies, and patient compliance do come into it. But I think, as opposed to Richard's statement that that there's minimal function at the DIP joint, I think especially on the ulnar digits, whatever function we can get out of the DIP joint is crucial for grip strength and general function. And I hope that when we go through these cases, you will be able to follow my logic and perhaps see that just simply leaving the FDP alone or perhaps fusing it is really not the ideal 21st century option for flexor tendon injuries.
Thank you so much, Drew. So let's have a look at the first case. And what we're going to do is exactly the same as Zaf did. And if you'd like to all use the Q&A to send questions to us, we'll try and address them as we go along. And just to remember that we're going to hear from each of our experts first, and then we'll take your questions, and then we're going to have a vote. And don't forget, you can change the view that you have on your Zoom from speaker view to gallery view, depending on which way you like to look at it. So we've got Jeremy here, 50-year-old male. He's self-employed. He's an electrician, and he needs to drive for his work. He had a zone 2 FDP division of his dominant little finger from a saw. It is infected, and he was attending hand therapy and doing well. So, Drew, would you like to make the case for repairing?
Well, this is a very interesting case, and I think all of us would have seen cases like this in our hand clinic. And this really has got way beyond an FDP repair. This is now an infected, troubled finger. And I think the initial approach here is obviously to remove all the sutures, debride it as necessary, and get this gentleman both into the dressings clinic and into the hand therapy clinic to try and rehabilitate this finger. This is not a case for doing a delayed primary repair. And I would then pretty much, once we've got the wound healed and we're content that everything's quiet on this finger, I would leave him alone with my hand therapist for probably 6 months. And if they then both come back to me and say, we would now like to regain some flexion of my DIP joint, I would then, together with my therapist, talk him through the possibility of reconstruction. But this is certainly nothing I would do in the acute phase.
And what do you think in terms of functional deficit for this gentleman to not have DIP flexion as an electrician and his dominant hand?
Well, I think the problem, I mean, you can cope with just about anything. And the thing is, with the little finger, he's probably either got no FDS or a small, weak FDS. So the likelihood is that his finger's going to end up rather extended. And if he goes back to his work after a month or two and finds that he can cope with having an extended finger with his job, then maybe there would be no case for even discussing tendon reconstruction with him. But I would want to see at that 6-month discussion with the therapist and him, if he did decide to go ahead for a reconstruction, a beautiful, soft, fully flexing, fully extending passively finger before I even had that discussion with him.
Perfect. So, Richard, would you like to answer to this case?
Yeah, I certainly wouldn't advocate a FDP repair primarily in this case. He's a 50-year-old Caucasian. Both of those factors will affect outcome. It's the little finger. We know the little finger does poorly, particularly in re-repairs. He's self-employed, so probably wants to get back to work as quickly as possible. He's a driver. He's not going to be able to do that for 3 months if he has a repair. It's a sore injury, so there's going to be frayed into the tendons, lots of edema. It's infected, causing more edema. He has a very high risk of adhesions and contraction with any further surgery, and I think he'd be far better served from getting moving as quickly as possible to preserve that much more important PIPJ motion.
I had a feeling you were going to say that. Absolutely. So do we have any questions? I haven't seen any so far. So if not, we'll just head to the next slide. Sorry?
There's a couple of questions there. Tom Schroeder.
Well, that was a general one. That one actually came before the case, but the question was, do you excise FDS if you have an FDP zone 2 injury? Is the first question from Andrei Lysek.
So excise FDS if you've got an intact, if you're repairing the FDP.
Well, precisely.
I think I tend to just repair the FDP if both are divided, and if if it's bulky, I would excise the FDS. Yeah.
And do you think with this particular case, the question has come in from Salman asking whether you think the end result's going to affect his driving? So to repair or not to repair? I suspect, Richard, you're going to say the most important thing here is his PIP joint.
Yeah, well, I don't think you need the little finger at all to drive. So I don't think it'll affect his driving, whether he can bend that DIPJ or not. Even if he can't flex the PIPJ fully, I don't think that's going to affect his ability to drive.
Yeah, so
but if he does have surgery and gets CRPS, for example, then that will affect his ability to drive.
So great question from Ton Schroders in the Netherlands. Hi, Ton. Richard, in the fifth finger, the FDS it might be missing, and as we know, it's quite common, or 12, 15%. Would you therefore not feel it's more important to address the FDP?
Well, I would always do this surgery under local wallant, and I would test the FDS on table. I'd test its strength. I'd make sure it's there. And I'd get the patient to have a look at it and decide whether it's sufficient for them. Obviously, if the FDS is weak or absent, then this argument doesn't apply. It does rely on an intact FDS.
Okay, thank you very much. Right, so let's move to the vote. So again, you're going to have 15 seconds to either go with Drew, the operative option, or Richard, the non-operative. I'm very sad to see that we're not allowed to vote. Okay, so who's it going to be? Oh my goodness. Okay, this is a whole Brexit situation, isn't it?
Exactly the same.
So it's exactly the same. So I think we need to see with the following cases whether we've got an audience who wants to operate or not. So this was Richard. This was your case. Would you like to talk through what you did with him?
He did have surgery. Did have the he had the wound washed out, and return of motion was not, but it was good enough for him to return to work and return to driving, and quite happy. Conversely, I've had patients with the same injury that have done very, very badly, that have had FDP repairs.
So before we close on this case, Gordon MacArthur's just asking Drew, would you always wait 6 months if the finger was quiet and you had full passive range?
Yeah, good question, Gordy. I think, you know, with a self-employed electrician, yes, because I'm not going to go back in on this finger within a month or two, because I think you are in a great deal of danger of stirring everything up. So I would certainly wait for a long period of time until I had a very lovely, quiet, fully passively flexing and extending finger before I did anything further. And, you know, and if he did have a strong enough FDS and good enough PRP flexion, we may well decide together not to do anything for his FDP.
Okay, thank you very much. So before we just move on to the next case, just to remind you that if you're putting in questions for us, please use the Q&A and not the chat, so that we, because otherwise we might miss them. So please use the Q&A function that you'll see at the bottom of your screen. So let's move on and look at Julie. So Julie is 38 years old. She's married. She's got a 2-year-old at home, and she's a professional clarinet player. She had a glass laceration of her ring finger and had a zone 2 division of FDP. It's her non-dominant hand, and she presents to you having had no intervention at 6 weeks. So, Richard, would you like to kick off the proceedings this time?
Yeah, well, firstly, she's got a 2-year-old at home. Unless she has a full-time nanny or a live-at-home partner, wearing a splint and doing rehab properly is going to be very difficult. She's a clarinet player, which means she needs independent ring finger motion. Your FDP cannot move your fingers independently, only the FDS can. And when you play a musical instrument, it's not just with DIPJ flexion, it's with as much with the flexion of the PIPJ and MCPJ as well. So I think she'd be able to play the clarinet fine, just with PIPJ flexion, and I'd ask her to try. It's been 6 weeks, so it's likely she's going to need a 2-stage procedure, so there's no urgency to operate, which means she can get back to activities of daily living, get back to music, and be really sure that this injury is actually limiting any of those things. And I think she'd find that she could probably manage. Okay,
thank you. And Drew, would you take her to theatre?
So I think at 6 weeks, the chance of you doing a primary repair of her FDP are probably relatively poor, and I think the only real option for her would be to consider a tendon reconstruction. I would again ask her to work with my therapist, bring her clarinet in, and see how she's coping. And I would leave her for a couple of months with the two of them to decide whether she can actually get on with the clarinet, and indeed how she's getting on at home without the DIP flexion. Now, as I said right at the beginning, I think DIP flexion and the ulnar-based ring and little finger are important, not only for fine function like playing clarinet, but also for power grip. And if between the two of them, they decided with me that reconstruction of the FDP was appropriate, I would then talk her through this. And for me, she would be the ideal case to do a 1-stage flexor tendon reconstruction.
Okay, so you wouldn't consider doing 2 stages with her. What would be your advantages of doing it in a 1-stage, and how would you make the decision? Would you look at the state of the pulleys?
Yeah, so I think going back in the early days when I first trained, we tended to default to 2-stage reconstruction, virtually all flexor tendon reconstruction. But with time and certainly listening to the teachings of both David Evans and David Elliott, I've gone to doing a one-stage reconstruction of virtually all circumstances now. The FDS is intact in this, so you can pretty much bank on the proximal pulleys A1, A2 being pretty good and reasonable. And really, you're only talking about the A4, which is probably collapsed down. And if you dilate that up with the urethral dilator, you can almost invariably get your graft through that. And even if you don't restore full FDP flexion, and I always tend to under-promise and over-perform with these, as long as they get 30 or 40 degrees with good tension in that reconstruction, that from a functional point of view is a very good finger.
Perfect, lovely.
Richard, sorry, I was just going to say, she obviously has to, with a 2-year-old, put up with the rehab, which is going to take her 2 or 3 months.
Yeah, at least. Absolutely. Richard, did you want to come back and say anything before we put this to the vote?
Just to say that, you know, she does have a 1 in 5 to 1 in 4 risk of having a finger that moves in a poorer way. If she gets adhesions or a contracture, then she may find she can't play the clarinet ever again. So I think she has to take on board that there is a risk, the operation has a risk of making things considerably worse.
So it sounds to me like it's all down to the quality of the therapist you're working with.
Hey,
as always.
What can I say? Okay, so let's move on and have a vote. So again, are we going to leave her alone as advocated by Richard, or are we going to take her to theatre and do a 1-stage delayed repair as advocated by Drew, who feels that she's got a better chance of getting back to her clarinet? Oh my goodness.
50-50. Good.
What can I say? So obviously the competitive spirit between the UK and Southern Africa is not quite the same as it is between the UK and across the pond with you, Glenn, over in the US. Julie was Drew's patient. Would you like to tell us what?
She's Richard's patient, actually.
Oh, it's Richard's patient. Sorry, got that one wrong.
So, Richard, you would do a reconstruction. There we go.
Well, this was in my earlier consultants. I think I got lucky this time, but it did take 9 months, and 9 months is a long time to take out of your music if that's your career, and also if you've got a 2-year-old at home, that's it's a big ask.
It's a big ask, but I spent a lot of time treating professional musicians, and it is very rare for them to not want perfection. And they're so super sensitive to the tiniest change in the way the forces of the movements go through their fingers that it doesn't surprise me that she opted for surgery on this occasion. So let's move on to our next case, which is Bill. So Bill is a 65-year-old man, and he's a carer for his wife. He's a passionate model maker, and he also had a Zone 2 FDP division using a kitchen knife. There's no infection. It's affected his dominant index finger, and he presents to you 1 week after the injury. He's very distressed at the lack of flexion, and he's asking for surgery. So Drew, would you like to make a case for operating on Bill?
Yeah, so that's an interesting one, and I think really careful discussion with Bill as to what is involved with caring for his wife. I think if his FDS is intact, clearly intact, and he's got a sensate finger, then I might well consider not operating on him. And why would I do that? 65, I'm a few years short of that, but I know you get a little bit stiffer. And if you then go for an FDP repair, you may well end up with a slightly less than good outcome here. But if he's really very distressed at the lack of flexion, I go back to my opening statement again. We've moved a long way from not treating flexor tendons. So I probably would say to him, on balance, as I'm there and opening up the finger, then I would repair his FDP. But I would really be very cautious about what his needs are with regard to caring for his wife. And, you know, also with regard to and the index finger and the model making a finger which doesn't have full flexion at the DIP joint, I think is not that important either. So probably hedging slightly towards not repairing this one.
Now that's, of course, completely not the right argument that you're meant to be giving. So Richard, I'm now going to challenge you to come on the other side of the scales here.
Oh, okay. You want me to advocate repair?
Well, I mean, you've been let down by your opponent.
Okay. Well, okay. I will advocate. In real life, I don't think he has anything to gain from surgery and quite a lot to lose. But if you want me to advocate for repair, well, it's a knife wound, so it's a sharp wound. So and it's quite transverse. So that's helpful for your repair. There's no infection. Doesn't look like there's any swelling. So good in terms of minimal risk of edema and adhesions. He's presented within the first week at least. He's very distressed about his lack of flexion. So, you know, he's obviously quite motivated to regain that flexion, which indicates that he'll be a good patient in terms of compliance. So those are the reasons why I would repair the FDP, although in real life, I think I would steer him away from it.
Sure. So a couple of questions. Anmar Al-Shawi is asking, Richard, do you categorically not repair or reconstruct FDPs?
No, I'm specifically talking about single digits where the FDS is intact. I repair flexors under Wallant. I let the patient see what they can do on table. And I simply ask them whether the movement they've got is enough. And also, you know, there is time. They could go away for a few days and see whether the movement they've got is enough. I let them have the choice. Sure. And I explain to them the pros and cons of repair versus no repair.
And there's a question from Jill Smith. Do you ever do a Leviette lengthening in the forearm to extend the length of FDP to do a primary repair when the patient presents late? So we're thinking more probably to do with the case that came before Julie, who presented at 6 weeks, rather than Bill, who's presented at 1.
Yes, although, you know, I suspect about half of flex tendon repairs in this country done by trainees. I doubt many trainees can send their patients preoperatively for a Leviette. So I don't think a Leviette is actually done very much in practice. And that's one of the, one of the components of my argument.
Sure. And Drew?
Yep, yeah, I certainly, and a common indication for me would be an FDP, a avulsion injury, especially in a young sportsman's. And classically, you know, they either present late if they're rugby players or sportsmen, and they will present it about 3-4 weeks down the line when they've suddenly realized that they've lost flexion commonly in the ring finger. And if that has popped back into zone 3, you'll find that if you actually then take it out to length and try and do your distal juncture, and I particularly use a transosseous juncture, you'll find that the PIP joint ends up almost at 90 degrees. And even if you Tina-D's the wrist into flexion, you can't convince yourself that you can get that finger out straight. And in that circumstance, I would certainly consider doing a Levitte in the forearm just to give that FDP another centimeter or two to make sure that you don't end up with a PIP joint contracture down the line.
Yeah, and this takes me back to the days of treating these FDP repairs over a button. So what distal fixation technique do you both like when you're repairing these?
For an avulsion?
Yeah.
I would drill bone hole, a transverse bone hole through the distal phalanx.
Yep. So I've been through all iterations from a button to a tendon out through the along the distal phalanx and tied back over the nail. But I certainly use a transosseous threoprolene now with a Bonnell type of suture into the graft or the FDP, whichever is appropriate.
Perfect. Thank you so much. Right, let's move to the vote. Let's see if we can do something other than an almost equal vote between the two of you. Thank you so much, Emma. So let's see if we can get something a little bit more controversial. Maybe these cases just weren't really controversial. Oh, look at that. 52 for this is really truly the Brexit situation, 52% and 48%. So what I would suggest that we do is, if we have a little look at one more case, and then open it up to the whole panel to have a conversation about flexor tendons, because there does seem to be quite a lot of controversy about these. It wasn't as clean cut as it was with the fractures. So let's just quickly have a look at Stephen. So he's a 23-year-old final year university law student who had a fracture 2 months previously. Find me a student that doesn't. He's got a painful non-swollen, non-dominant ring finger, and he's had that pain for 2 weeks. No medical input, no flexion of the DIP, and found a lump in his palm. Got some mild pain. So he's got a closed fracture avulsion of FDP. His x-ray is normal. He has got a palmaris longus. So he plays racket sports for his university, and he doesn't want to give it up. And to add to the complications, he splits his time between university and a rural, distant home far away from the hospital that would be repairing. So let's start. Richard, what would you do with Stephen?
I would try and avoid doing an FDP repair in this patient. I think there are lots of things here that indicate he might get a poor outcome. So he's been involved in a fight, so he's obviously somebody who is prone to behavior that isn't conducive to a good outcome. His finger's already swollen, so it's already edematous, so he's more likely to get adhesions. He's not engaged with healthcare for 2 months. He's got a lump in the palm, which indicates the FDP stump is probably in the palm, so he's more likely to need lengthening or a 2-stage procedure. He's only got mild pain with activities of daily living. That pain's likely to go. So if he could do his activities of daily living, what does he have to gain? He wants to play racket sports, doesn't want to take time off. I'd quite like to know whether he can play racket sports now, or whether with a bit of therapy, he could get back to playing racket sports. He splits time between home and university, which means rehab is going to be complicated. Where's he going to do it? I think he should get back to his racket sports. And if he can come back and tell me and that he can hold his racket suitably, I think he's far better off not having surgery. His profession's unlikely to be affected by inability to flex the DIPJ. He's a lawyer.
Thank you, Richard. And Drew, would you operate on Stephen?
Okay, so this guy's got a lot of things going for him in terms of suggesting a tendon reconstruction. You guys were slightly at cross purposes here. The slide says a non-dominant, but he's a racket player, so this looks like his left hand to me. So if we assume it is his dominant hand, and that's his racket holding hand, your little and your ring, and indeed your middle finger are pretty important for holding a racket. He's young, he's got a good finger otherwise, although it is at this stage not ready for any reconstruction because it's swollen and has incomplete passive flexion. At 2 months, in my book, this is too late to try and do a delayed primary repair, especially with the proximal stump curled up in his palm. So this is a chap I would again encourage to spend a lot of time with my therapist, and that's really to test his compliance, and so that the two of them can chat through possible reconstruction and the rehab thereafter. And I think if they then came back to me in a month or two with a beautifully soft, passively fully flexing finger and said, right, we've decided between the two of us that we would like you to contemplate a flexor tendon reconstruction, I would go for a 1-stage flexor tendon reconstruction in this chap using his ipsilateral palmaris.
Thank you. And Richard, just a question from Ernesto Martin in Mexico City. Have you seen long-term compensatory deformities or DIP fusion due to not repairing the FDP? So do these patients come back to you down the line?
Not personally, but you know, I don't have a huge case series of this kind of patient, but the ones that I have treated this way have not come back with problems. And I've yet to find a paper in the literature that describes the natural history of these injuries that are not repaired. So I think the reality is we don't really know what happens, but I don't think anybody's proven that people do particularly badly from it. Certainly, we don't see patients coming to clinic with untreated FDP injuries years later with deformities.
Yeah, I would agree. I would agree. And I looked to see if I could find a paper that reviewed long-term results of people who choose not to have surgery, and I couldn't find one. So there's a paper waiting to be written. Another question which is coming through: which transosseous technique are you both referring to?
Sorry, what was that? Which
transosseous technique are you referring to when you're repairing?
Well, I'm just referring to just a transverse bone hole across the tuft. I think Elliot has described that, you know, with a Kessler-style stitch into the stump.
Okay.
There's lots of different ways of doing it, though, aren't there?
And another great question, which is, if you've got a full division of FDP and a partial division of FDS, what level of FDS injury are you prepared to leave without the FDP repaired?
So you've got a FDP division and a partial FDS. Mm-hmm. Oh, so in terms of percentage,
yeah,
that's a good question. I think. Well, I think as in other tendons and zones, probably 50%.
And Drew?
Well, I think if you're going to, I advocate operating on these patients, and I think if I've got a 100% FDP and whatever percentage of FDS, I'm going to repair them both acutely if this is an acute injury, but I'm going to be absolutely sure that at the end of my repair, that this repair, which is going to be bulky, is running through all pulleys in that neighborhood, both in full tenodesis and flexion. If they're wide awake with Wallant, then they can do it themselves, and I want to make sure there's no gapping. If the FDS is catching at all, then I'm going to get rid of the FDS repair completely and just leave the FDP. To my mind, the FDP is the crucial tendon to get going in this finger.
Perfect.
I just say that the reason for not repairing the FDP is so that the patient can mobilize straight away. If I think the FDS is damaged enough that it's going to need protection, then the argument doesn't hold. It has to be strong enough that they can mobilize fully straight away.
Okay, so let's have a little look and see, have a vote on this last case before we take one or two other comments. If you'd like to vote now. So with Stephen, are we going to operate or are we not? And while people are voting, Drew and Richard, if you can have a think, I think there is a young surgeon out there who is asking if he's got a jersey finger non-fracture avulsion, then would you operate or would you not?
So a young surgeon who has a
so-called jersey finger, so an avulsion but non-fracture.
Non-fracture, yeah, I would operate.
Richard?
So it's his ring finger, is it, on his dominant
ring finger?
Okay. Well, I would want him I'd want him to tell me what he can and can't do with his ring finger. If he can do everything, including operate with his ring finger, I'll then ask him, okay, we can give you a bit of DIPJ flexion. Are you prepared to take the 1 in 4, 1 in 5 risk that you get a contracture? And
so is that a yes or a no, Richard?
Currently have.
Are you going to leave it?
Probably, unless he insists. But he's got to prove to me that there's something he's got to gain that is worth risking loss of PIPJ motion for.
Okay, so my advice to that young surgeon is you now know which surgeon of the two you're going to go and take advice from. So if you want surgery, go down to Tooting to see Drew. And if you want to be sent away and told to get on with your career, then you need to head to Slough to see Richard. So I'd like to just finish there and say thank you both very, very much for participating in the second debate of the evening. And I'd like to hand back to Zaf to make some closing words. Zaf muted himself.
Thank you. Thank you very much, Nicola. Thank you for the fantastic debate. I think Drew got it there at the end. So we had 3 score draws, and then Drew kind of had the knockout punch at the end there. I'm sorry about that, Richard, but it seems the final question was to what Drew won that one. So I want to just thank everybody, really, all our expert speakers. First of all, Drew Fleming, Richard Baker, Glenn Gaston, all the way from America, from very far away, but great technology these days. We can have people from all over the world, just like that in an instant. And of course, Professor Gray Giddins. There's been obviously quite a bit of work behind this project, which started 2 or 3 weeks ago. So Emma from the BSSH office has worked very hard alongside Max Howritz, and both of them, I would like to acknowledge the work that they have done also. This was, as David Warwick said, was supposed to be our society dinner right now. We would all have been there in London enjoying the dinner, and we would have been in full swing in what would have been the first of David Warwick's conferences as president of our great society. And these things come along very few and far between. And I'd like, on behalf of all the members of the Hand Society and on behalf of all the committee members of the Society, sincerely wish the best for David at this time. He would have been working for nearly 2 years on the conference that we would have had in London right now. And it was just this is just a very small gesture from the comms committee, just to acknowledge David and what would have been a fantastic conference in London if it wasn't for the global crisis. David, we're getting thanks and congratulations from across the world here. Caroline Leclerc has just sent her congratulations from Paris. You know, there's people registered here from Russia, all the way across to Colombia, South America, Canada, the US. And it's a small gesture, really, what would have been a fantastic conference for you, David. So thanks from me, and thanks to everybody who's worked on this. Thanks for all the people who've participated. Please give your feedback. Emma will send out feedback to you now, and maybe we can do this again, maybe other topics of debate. And I'm going to hand over now the final mic to David Warwick, our president of this year. David.
Was that? Thank you. So that was so kind of you. I got a tear in my eye in front of 500 people. So thank you so much for that, Zaf. But really, just the final few words, just from the BSSH, from all of us here. Zaf, thank you for being the brains behind all of this. But from the BSSH to everybody out there, all 500 of you, please, 2 rules. Number 1, stay safe. And number 2, be kind to each other. Thank you all for coming. God bless.